Hey y'all, Dr. Maynard here. I'm excited to speak to you about the McKinney Fire pre-hospital blood program. This has been a long time in the making, and a lot of research has gone into this program to make it successful. This program keeps McKinney Fire on the cutting edge of patient care. Due to our efforts over the past few years, we've seen an amazing increase in our ROSC rates for medical cardiac arrest. Now we turn our efforts towards a new goal of treating hemorrhagic shock in the field, whatever the cause, trauma, GI, or OBGYN bleeding. So we need a new tool, and that tool is pre-hospital blood. So let's start with the case. We have a rollover MVC on Highway 75. You see that a 35-year-old female who was unrestrained is now partially ejected. Her leg is trapped underneath the dashboard. In the injuries we can identify right now, her left femur has pulsatile femoral artery bleeding, and she's got abdominal bruising. Initially, she's alert, but then quickly becomes confused, pale, and diaphoretic. Her vital signs, she's rapid and shallow breathing and has a thready pulse. So what's your plan? Well, we'll come back to that later. All right, so what are our objectives of this video? We want to explain why pre-hospital blood is a good idea. We want to review hemorrhagic shock. We want to go over the literature. What does the literature say? What does the science say about pre-hospital blood? We want to become familiar with the terminology of blood transfusions. We want to understand the complications. And a little note, the equipment, the protocols, and the logistics are all going to be covered in a separate training. So don't worry about that. That'll come later. Also, before we get fully into this, I want to thank the Parker County Hospital District and Frisco Fire for their help because they've already done a blood program and been very successful. And so we have borrowed from them and they have graciously offered. So you might ask yourself, is this really a good idea? Well, several academic groups say yes. In fact, they put out a position statement stating that pre-hospital blood should be encouraged when possible. You don't have to read through this whole statement. I've summarized it here for you. Exsanguination remains the leading cause of preventable trauma death, with nearly half occurring in the pre-hospital setting before they ever get to the hospital. They make recommendations for external hemorrhage. Of course, for extremity hemorrhage, we're going to apply direct pressure. And if that doesn't work, they recommend a commercial tourniquet. But for our non-compressible sites, like on the thorax or the abdomen, they recommend hemostatic gauze or wound packing. And here's the big one. They recommend that for patients in hemorrhagic shock, they should receive pre-hospital blood. So this is a ringing endorsement from some of the biggest academic agencies out there, the American College of Surgeons, the National Association of EMS Physicians, and the college that I answer to as an emergency doc, the American College of Emergency Physicians. They also say, let's prioritize low titer type O whole blood. And we'll talk about that later, what that means. All right, so a little background. When people die from traumatic cardiac arrest, what are the causes? Well, the major cause is hemorrhage, about 55%. Another 13% die of hypoxia or asphyxia. Tension pneumothorax takes about 10% of those people, and cardiac tamponade, another 10%. So, as you'll note, for the majority of the patients, we don't have an adequate treatment. Basically, we can treat tension pneumothorax and cardiac tamponade. For tension pneumothorax, we can do finger thoracostomy or bilateral darts if they're in cardiac arrest. For cardiac tamponade, we can do pericardiocentesis. For hypoxia, of course, we can intubate, we can give oxygen. But for hemorrhage, we really don't have a solution, and saline is not the answer. For the different types of hemorrhage, we've got extremity, which of course are compressible, and we know that we can do direct pressure or put a tourniquet. And for truncal or non-compressible, we know that we can pack the wound, we can give TXA, but coming soon, we'll be able to give pre-hospital blood. And of course, ultimately, we need to get that patient to the hospital so they can get the surgery that they need. All right, so who's already doing this? Basically, in 2025, about 250 ground aid agencies are doing this. Well, that's only about 1 to 2% of all US agencies. In Texas, San Antonio was kind of the leader. They had the first program in Texas, but we all see clusters of pre-hospital blood being given in Houston and also the DFW area. Now, in our region, in DFW, we have Parker County giving blood, Fort Worth Fire, Arlington, Dallas, Frisco, and Saxe Fire giving blood, and soon McKinney Fire. So, who should receive pre-hospital blood? Well, basically, patients that are in hemorrhagic shock. So, we think about the trauma patient that has either internal or external hemorrhage, the MVC blunt trauma, or the penetrating trauma from a GSW or a stab wound. But also, don't forget about the dialysis fistula that bled after a dialysis encounter. Also, think about GI bleeding. We think about that cirrhotic patient with esophageal varices who's vomiting and a tremendous amount of blood. That patient's going to get sick really fast. Or the lower GI bleed who's on Eliquis or some other anticoagulant. Also, don't forget about OBGYN vaginal bleeding. These patients are often neglected. Note that approximately about 50% of pre-hospital blood in our area is being given to patients that are non-traumatic. In other words, about 50% are medical patients. All right. And you might ask yourself, if we have two level two trauma centers within city limits of McKinney, is there really any benefit to pre-hospital blood? Can't we just get the patient to the hospital and they can give the blood there? I think you'll find that that's not the case. But you might ask yourself, hey, is the juice worth the squeeze? I would say, well, if you're that patient, it probably is. And I would say, if you're the family member of that patient, or if it's your family member, you'd probably agree that you'd want pre-hospital blood given. Some may also say, this sounds really complicated. Do we really need to learn about all this blood transfusion? And I would say that if paramedics can recognize sepsis in the field, which is really confusing and difficult, even for an ER doctor, they can recognize hemorrhagic shock. Let's take a look at our performance in ESO. This is data collected recently. So in 2025, our code 3 transport times for critical patients, our scene time is about 15 minutes. Our transport time is also about 15 minutes. So that's the total time with the patient of about 30 minutes. Remember, of course, this does not count the time from injury to patient contact because we don't have control over that. All right, so let's continue with this case. We've got our rollover patient who's partially ejected. What are our priorities? Well, we want to make sure that her airway's intact, and it is. We want to make sure that she's got equal breath sounds, and she does. Go on to circulation. We place a tourniquet to the right leg, and that stops that arterial bleeding. Great, we've stopped the bleeding. Disability. Her GCS is now 6 because she's lost a lot of blood, but her pupils are equal. We expose, and we don't find any other injuries other than that abdominal bruising. Extrication takes about 15 minutes, during which her vital signs decompensate. Now her heart rate is 125 and her BP is only 60, but she's oxygenating well. So this is a bad combination, that high heart rate and low BP. This brings me to a point. Our biggest challenge in trauma is really time. Patients decompensate not in hours, but in minutes. Now, what would you say the difference is between a campfire and a forest fire? I would argue it's time. And if your only tool is a bucket of water, when do you want to use it? Early when it's a campfire or late when it's a forest fire? How effective is it depending on when you give it? Now, what's the difference between compensated shock and death from hemorrhagic shock? Again, I would say it's time. If your only tool is a unit of blood, when do you want to use it? Early on in the process when the body has reserves and might be able to clot off the bleeding? Or do you want to give it later when endothelial injury and multi-organ dysfunction has developed? If we wait too long, our unit of whole blood isn't very effective. At this point, we need MTP, or massive transfusion protocol. Time in EMS is always the enemy. This is not something that we are foreign to. What do we call local ischemia in the myocardium? We call it a STEMI, when you can't deliver blood to part of the heart through that coronary artery. And we say time is muscle. What about local ischemia in the brain? Well, we call that an ischemic stroke. And we say time is brain. What about ischemia to the whole body now? Every organ system. Well, we call that hemorrhagic shock, and you can see every organ is involved. This is worse than either of those further cases. And so we should call this really whole body ischemia. And that brings us to the trauma triad of death. When you have blood loss, it leads to hypotension. The body compensates by increasing heart rate and blood pressure. Unfortunately, this lack of blood flow to distal organs causes lactic acidosis. And we can see at the bottom right, that's where we pick up. That lactic acidosis decreases the heart muscle performance, and that leads to a lower body temperature or hypothermia. Now, when the body is cold, our coagulation factors don't work as well, and so blood clotting becomes a problem. We call that coagulopathy, which leads to further decrease in blood flow and lactic acidosis, and down the spiral we go. So our traditional treatment for patients who are in traumatic hemorrhagic shock is we would give them normal saline or lactated ringers. So it's a short-term solution. We can expand the volume and increase the blood pressure, but it really doesn't do all the things that blood does. So the problem is that there's no platelets or coagulation factors in the normal saline. So it causes dilutional coagulopathy, basically dilutes the Kool-Aid, if you will. So we replace what's lost, which is whole blood. And don't forget to warm the patient. Now, in the past, there was mostly military studies on giving blood in the field, but now there's a growing number of civilian studies to guide us towards optimal patient care. So I'm going to summarize the most pertinent literature on pre-hospital blood over the next few slides. First, we have the Watts study, which was in resuscitation in 2019. The objective here was to see the effects of close compressions, whole blood, and saline on resuscitation of pig model, porcine model, on traumatic cardiac arrest. They had 5 different groups and they studied 40 different pigs. So this is how the study worked. Basically, in phase 1, they did a controlled exsanguination. They bled out these pigs until their MAP was about 45, which is pretty low. That's about 30% blood volume. And that was the original injury, if you will. Phase 2, they held the MAP at 40 to 45 for 60 minutes to simulate shock and allow all of that inflammation and endothelial dysfunction to accumulate. Then in phase 3, they bled the pigs out even more till the MAP was 20, and that caused cardiac arrest. During that phase, then they did 3 cycles of resuscitation according to their group. In group 1, they only got compressions. Now remember, this is traumatic arrest due to blood loss. So that's probably not going to work. Group 2, whole blood. Group 3, normal saline. Group 4, whole blood plus compressions. Group 5, normal saline plus compressions. And then they watched for the response. So what were the results? All subjects in the compressions only group died. All subjects in the whole blood group actually survived. And what we found is that whole blood uniformly improved the outcomes versus normal saline. In addition, the compressions had a detrimental effect on the whole blood plus compressions group and the normal saline plus compressions group. So anytime a patient had compressions, they had a more significant metabolic acidosis, which led to increased tissue ischemia. So the bottom line here is that whole blood helped for traumatic cardiac arrest, and continuous compressions actually caused harm. Now, we have a human trial, the PAMPER trial, which is a pretty well-known trial. This was done in 2021, and we can see that they compared hypotensive patients in the setting of trauma that were transported by air medical. And they basically gave them either crystalloids, plasma, PRBCs or packed red blood cells, or the combination of PRBCs and plasma. And what we found is that the worst outcome was for crystalloids, basically because they have no clotting factors and no O2 carrying capacity. And the best was the PRBCs and plasma. Also, if you look at these trend lines, we can see that the plasma group actually did better than the PRBCs group, but not as good as the combination of PRBCs and plasma. So the bottom line is that blood is superior to saline in the setting of hypotensive trauma patients. Next, we have the STAMP trial. This has to do with TXA versus placebo for hemorrhagic shock patients, and this was given by ground EMS. And what we see is that TXA actually didn't do much to reduce 30-day mortality, but it did show some benefit for severe shock, especially if it was given early. And early would be defined as less than 2 hours. Furthermore, TXA was safe. It didn't have any negative side effects. So the bottom line here is that TXA is safe and the benefits in severe shock, but also remember to give it early. All right, and now probably the most important article that we're going to talk about here, the Deeb article from 2023. This was a secondary analysis of both the Pamper trial, remember that was the one that compared blood to saline, and the STAMP trial, which was the TXA trial. And it basically looked at what they call TERI, or time to early resuscitative intervention. This is defined as the patient has the injury and the time it takes to have some type of either pre-hospital intervention, or if no intervention was given, then it's the time to get to the hospital. And then they intervene at the hospital, of course. All right. And this is an amazing statistic. Every 1 minute delay in intervention, or TERI, was associated with a 2% increase in mortality. So remember, 1 minute delay equals 2% mortality risk. Now, let's go to Mckinney Fire. Our critical patient in our ESO data from scene to transport, we're with the patient for about 30 minutes. So now do the math. After about 30 minutes, the average hemorrhagic shock patient has about 100% mortality risk. So will pre-hospital blood make a difference? I think so. All right, let's summarize. The Watts pig study for hemorrhagic shock, whole blood help, continuous compressions harmed. The Pamper trial, remember, blood is superior to saline. Saline is not what we should be giving patients in traumatic cardiac arrest or any type of hypotensive hemorrhagic shock. The STAMP trial, TXA is safe. It really benefits severe hemorrhage, and it's best when it's given early and in less than 2 minutes. And then the Deeb article, of course, says that every minute delay increases our mortality by 2%. All right, so let's switch gears now. We've got to talk about blood terminology. Blood transfusion medicine can get pretty complicated pretty fast. So let's try to simplify what we need to know. Whole blood, when you take it out of the vein, it can be separated into components. And so we do that by spinning it down in a centrifuge. And you can see it separates out into layers based off of how dense it is. So if we took whole blood, we could separate it out, and then we could actually separate those different components into separate bags. And this is what we call component therapy, or CT. Component therapy is pretty common in hospitals. In fact, that's what we give in the ED. There's three main components. There's PRBCs, which of course do the oxygen carrying. There's platelets, which provide the first step of clotting. And then there's FFP, or fresh frozen plasma, which contains the clotting factors, which is the second step in making a clot. MTP, or massive transfusion protocol, is basically when we give a ton of blood to a patient or replace their entire volume of blood within about 24 hours. And we usually do it in a 1:1:1 ratio. So that's PRBCs to platelets to FFP. Now, whole blood, you can see on the right versus component therapy on the left. You can see that in whole blood, everything is in one spot, whereas component therapy, you've got to hang three different bags. Whole blood is minimally processed. It's only leukoreduced, which means they take out most of the white blood cells, and then they anticoagulate it because, of course, you can't give clotted blood through the IV. We use a anticoagulant called citrate. Now, the benefits is that it's one bag, and so it's simple, it's easy to give. That's why we prefer whole blood. It has all the oxygen delivering capacity, it has all the clotting platelets and clotting factors, and there's no thawing delay like we would need for frozen plasma. Additionally, there's less exposure because you're only getting the blood from a single donor. It basically replaces what was lost. Now, let's talk about blood types. There's the ABO system, and it's basically named for the antigen that's on the red blood cell. So you can see you've got a schematic of a red blood cell. This one happens to be a type A, and these little proteins that are on the surface are what we call antigens. And so there's four groups. There's type A, which has the A antigen. There's type B, has the B antigen. And there's A and B, which has both A and B antigens. And then O has no antigen. And then there's RH antigen as well, also known as a D antigen. The Rh antigen is either there, we call it positive, or it's not. Then we call it negative. And so an example would be O positive. That's of the ABO groups, it's type O and it's Rh positive. So we call it O positive. Now, in our ABO blood group, there's antigens on the surface of the proteins, and then we make antibodies against those antigens. These antibodies are made by the immune system, and they basically attack pathogens, but sometimes also attack foreign blood. So an antibody is going to attach in a lock and key type mechanism to the antigen. The ABO antibodies occur naturally. You're basically born with them. So let's do an example. If you have type A blood in the first column, you are born with antibodies against type B. We call those antibodies anti-B antibodies. So if you have type A blood, you can receive only type A blood or type O blood because, as you can see, type O has no antigens to be exposed to. All right, of the blood types, how common are they? Well, O positive is actually the most common, and that's about 38% of the population. So it's really easy to get donors from this blood population. All patients can receive this blood, but it may be a problem if you have a pregnant patient who's Rh negative, and we'll talk about how that is in a minute. O negative is not so common, but it's the least risky of all the transfusion reactions, meaning that it would be the safest. Everybody could get type O negative blood, but it's only about 7% of the population. So it's really hard to find donors. Let's talk about ABO compatibility. If a patient's antibodies attack a donated RBC, that can lead to what's called hemolysis. So basically, the antibodies attack the donated blood and cause it to break open, and it releases the hemoglobin into the blood. So an example, a patient is type A, has anti-B antibodies, and we give them type B blood. Now, those anti-B antibodies are going to destroy the donated type B blood. And we call this an acute hemolytic transfusion reaction, and this can be deadly. The universal donor is type O negative. So there's no antibodies and there's no Rh antigen. So it's safe for all people to receive. The problem is it's really rare and hard to get donors. Their universal recipient would be AB positive, but there's in this case, there's no anti-AB or Rh antibodies. So they can receive any type of blood. Now, let's talk about Rh factor. So this is an additional antigen that's on the red blood cells. But unlike ABO, anti-Rh antibodies are not naturally occurring. You have to be exposed first. So they only develop after exposure, either from a blood transfusion of Rh positive blood to an Rh negative person, or you have a pregnancy with an Rh positive fetus in an Rh negative mother. So if the Rh negative mother is exposed to Rh positive blood, it's going to develop antibodies to the Rh antigen. And eventually, if it sees those antigens, it will attack and cause hemolysis. The mother's immune system may actually attack its own fetus. And you may be asking yourself, well, where did the Rh positive fetus come from? Well, it probably came from dad, who was Rh positive, in an Rh negative mother. All right, let's talk about some complications. We're going to talk about the following complications in the next slides. All right, let's do a case. We have a 35-year-old female who's 35 weeks pregnant. She has massive bleeding, which is about 1 pad per hour over the last 20 hours. So that's a good amount of bleeding. Her blood pressure is very soft. Her heart rate is too fast. That's a pretty bad shock index. And so we give her 2 units of O positive pre-hospital blood prior to arriving to the hospital. She goes straight to the OR, and OB performs an emergency C-section because the patient had a placenta previa, and the patient and the baby survived. So great success. But we find out later the mom is Rh negative. Oh, that's a problem. So what's the risk? Well, that her blood, her immune system has never seen the Rh antigen. And so if the baby was Rh positive, well, we gave Rh positive blood. And so the risk now is that mother could develop an immunization against the Rh antigen. We call that Rh alloimmunization. So this is when an Rh negative mother develops an anti-Rh antibody after exposure to an Rh positive blood. So this is really not a risk for the current pregnancy, but the future pregnancy. So the mother's going to develop these anti-Rh antibodies and then may attack the fetal RBCs if that fetus is Rh positive. But generally, this is low risk. Females who are Rh negative are only about 10 to 12% of the population in the DFW region. So we're already dealing with a small subset of patients. And then Yazur found that modern day probability of these bad things happening, fetal death, significant morbidity, because of this anti-Rh antibody is only approximately 0.3%. So what do we do? Well, females who are Rh negative may need RhoGAM at the hospital, but we can give this after the fact. We don't have to give it before we give the blood. This is a medication that hides the Rh antigen from the mother's immune system so that she doesn't make antibodies to the Rh antigen. So the bottom line, if the mother's in hemorrhagic shock, that is a big problem. That is high risk of death. So the benefits of giving her O positive blood way outweigh the risk of Rh alloimmunization. All right, now we're going to talk about transfusion reactions. This can seem a little overwhelming at first. We're going to try to simplify. All right, so our first type and most common is febrile non-hemolytic transfusion reactions. It's a mouthful. The cause is basically there's cytokines from the donor's white blood cells or the recipient's antibodies to donor leukocytes, white blood cells. This happens right away. The symptoms are mild fevers and chills, and basically we give Tylenol. The severity is pretty mild. It's a pretty common reaction, but it's been reduced with modern blood filtering. Number two is a big problem. This is acute hemolytic transfusion reaction. This is when you have ABO incompatibility. For example, giving type A blood to a patient who has O blood. The recipient antibodies attack the donor's red blood cells. But remember, this should not happen if we're giving type O blood. This happens pretty quickly in minutes to hours. The symptoms are fever and chills, but now we get new symptoms of blood in the urine or hemoglobin in the urine, hypotension. They can even go into DIC, which is very serious, renal failure. So we stop the transfusion immediately, supportive care like giving fluids and diuretics, and then report back to the blood bank because they're going to need to know about this. The severity, that's potentially fatal. Number three, another reaction is an allergy. This is caused by antibodies against donors' plasma proteins. And so this happens right away. We've seen this before. Allergic reactions, urticaria, hives, itching, wheezing, hypotension. If it's severe, we call it anaphylaxis. And so we know how to manage this. We can give Benadryl, we can give dexamethasone, we can give Solumedrol. And if it's really severe, we can give IM epinephrine for anaphylaxis. The severity is mild to life-threatening, depending if it becomes anaphylaxis. A more rare cause of transfusion reaction would be TRALI or transfusion-associated or related lung injury. And this happens pretty quickly. And this is when a patient basically develops ARDS or acute respiratory distress syndrome. They are hypoxic, they have pulmonary edema on their chest x-ray, and they have fever. So these patients need supportive care such as oxygenation, maybe even intubation, and we try to avoid diuretics in these patients. The severity is pretty high, and luckily this is a pretty rare cause. The last one we're going to talk about, and the fifth one, is TACO or transfusion-associated circulatory overload. And this is basically we're giving a fluid to the patient. And so if they are going to be prone to volume overload from CHF, from renal failure, they're going to develop pulmonary edema, which is basically cardiogenic pulmonary edema. All right, so how common are these reactions? Well, the febrile transfusion reaction happens about 4% of the time. So you have to give quite a bit of blood transfusion in order to see this. Allergic reactions are the next most common, and they're less than 1%. The others are even more rare than that. So You want to know about transfusion reactions. You want to be able to spot them, but just remember that they're not very common. All right, let's summarize because that's a lot to take in. Transfusion reactions are rare, but the most common is a mild fever. So you can give Tylenol. Allergic reactions are easy to spot: itching, raised rash, urticaria, bronchospasm, and we know how to deal with that. We can give antihistamines and steroids and IM epi if they're bad enough and they've developed anaphylaxis. The life-threatening acute hemolytic transfusion reactions, this is the bad one. That one should not occur if we're giving type O blood. All right, another complication is hypocalcemia. When blood is preserved with citrate, it binds to calcium. That's what it's supposed to do. The problem is that the citrate is still in the blood. When we give that blood to the patient, it's going to bind the patient's blood calcium. So citrate is going to cause hypocalcemia if we give enough blood. Well, how much blood? Well, it usually happens about after 4 units, but it can happen as in little as 1 unit. So the bottom line is that when you give blood, you should also give calcium gluconate with the blood in order to avoid this problem. All right, so let's talk about patient consent. Patients have the right to refuse blood if they're conscious. So if the patient has decision-making capacity, they understand the risk and the benefit, they should receive informed consent. So this will be in the protocol. Just read this verbiage to the patient. We believe the patient has life-threatening hemorrhagic shock, and the benefits of blood transfusion outweigh the risk. The risks include allergic reaction, transfusion reaction, and transmission of disease such as HIV or hepatitis. But the risk of obtaining this disease is about 1 in a million. Do you consent to transfusion? And then proceed accordingly. If a patient is in such bad condition that they can't respond, they can't make decisions, they don't have decision-making capacity, then you can make the call for them. And that covers us under implied consent. You should evaluate for religious exemption. If the family says, hey, this patient is a Jehovah's Witness, they would not want blood, then you should honor that patient's wishes or call medical control for further guidance. All right, so at Mckinney Fire, what will we give patients? Well, we're going to give low titer type O whole blood, probably Rh positive or O positive, and if possible, Rh negative. So what does low titer mean? Low titer means that they have low levels of the anti-A and anti-B antibodies. So this minimizes the risk for transfusion reactions. Type O, of course, is the universal donor. We can give this to anybody, and they should be able to accept it without an ABO incompatibility. And it's usually going to be Rh positive. Whole blood, because it contains everything we need for oxygen delivery and for clotting. It's the most desirable for pre-hospital blood programs. We need to keep it stored at 1 to 6 degrees Celsius. That'll be covered in further lectures, and it can be stored up to about 35 days, depending on when we receive the blood. It's about half a liter of fluid that we're going to give to the patient, and the infusion time takes only about 1 to 3 minutes, depending on how we're infusing it. And the cost of whole blood is a little bit more than component therapy. If needed, we can give component therapy such as PRBCs and plasma, but we prefer blood if we can get it. All right, so some take-home points. Exsanguination still remains the leading cause of preventable death. Pre-hospital blood is part of that solution in addition to other interventions. Every 1 minute delay in intervention leads to a 2% increase in mortality. We can make this happen. Thank you for your time.